Thanks for the invitation to speak today. I'm excited about this topic and look forward to the discussion that we will have afterwards. So I'm going to talk about, who's at risk for micronutrient deficiencies and how do we need to pay attention to this? I think many people have seen this diagram. When we are involved in this world of nutrition support and intestinal failure, one of the biggest things that we think about is where, what part of the intestine is lost. If there is missing intestine, you can have dysmotility disorders as well. And that's really going to guide on what kind of micronutrient deficiencies patients are going to be the most at risk for. We can see here with this diagram, you need to think about, the ileum. The ileum is an area that's required for full absorption of B12 and your fat-soluble vitamins due to the bile acid reabsorption from that area. Your jejunum, that is an area where you're going to have a lot of your absorption of your different micronutrients, but even going down to your colon, you're going to see water and some electrolytes absorbed. So really knowing the anatomy of your patient is important when we start to think about who is at risk for micronutrient deficiencies. So I think to best understand this, I want to look at a case. So our case is a 5-year-old male with a history of gastroschisis and ileoatresia. His anatomy at the time of his surgery, his most recent surgery, was about 20% of what it was expected for his age. And he has a small bowel that's anastomosed to his hepatic flexure, so does not have his ileocecal valve. Over time, had been slowly increasing his feeds based on tolerance and was, as you look here, getting about half enteral nutrition and half parenteral nutrition. In his parenteral nutrition, he was getting a daily multivitamin and individually dosed trace elements. Now we all run into issues of a recent multivitamin shortage, and due to his proportions and following ASPEN guidelines, since he was about 50%, we removed the multivitamin from his PN and started an enteral multivitamin. About 6 weeks later, though, family calls to report that he has increased vomiting. He was walking like he was drunk and his eyes appeared crossed. He actually saw a local ophthalmologist who was found to have nystagmus and a bilateral sixth nerve palsy and retinal hemorrhages. Subsequently was diagnosed with Wernicke's encephalopathy, and you can see a very low thiamine level. Why did this happen? It's a big concern we all have. Was it that he couldn't absorb the multivitamin to the extent that we were hoping he could with his intestinal resections? That probably has been a role, but it's actually deeper than that. And it's more than just what the anatomy is and what patients can absorb. We found that his family was not giving the multivitamin because he started vomiting with it. And we had thought he was getting 7 feeds a day, but he was actually only getting 6 feeds a day. And so this meant that his thiamine provision was 0.7 milligrams per day, and his needs were estimated at least 1.2 milligrams per day. This brings me to kind of thinking about the risk factors for vitamin deficiencies. We know that your intestinal resection, what anatomy you have, is a risk factor. But there are other things we need to consider. One thing is going to be your body stores, and that's going to relate to the timing and presentation of deficiencies. Thiamine, you have about 4 to 6 weeks of body stores in that in general. And so you're going to see that more acutely as a deficiency that might present. Things like B12, you actually can develop, if you have adequate status, your body stores, they might not be depleted until up to a year later. So knowing that. There's also things about communication, right? We have our families here, like this person down here, walking on a tightrope. And so any little thing can push them over. So communication is clear and important. In this case here, I think we thought more about how we were asking what feeds the patient was on. Really, we need to go in with open-ended questions and walk through, how are you mixing your formula? Walk through the day step by step. Don't ask questions like, any changes? Maybe there weren't, but maybe they weren't getting what we expected. Or are you getting this, this, and this? Then they might just say yes if they aren't sure. And so this open two-way communication is really important to assure adequate provisions. There's also communications between different care providers. Kids may, have multiple people caring for them. Maybe they missed some feeds at school. Maybe they have a babysitter who didn't give a feed. And so making, people who care for children as well, maybe not be communicating or may have difficulties with communication. And then there are things like illnesses. When you have someone who's on this tightrope, any illness, a viral illness, a gastroenteritis can push a kiddo over the edge, and where they may be doing fine, that might be just too much and they can push them over. And one thing that we run into specifically in pediatrics often is changing needs over time. It is not infrequent that at the time of puberty, kids may have steps back. Thinking about that, their nutrition needs increase during that time. And so it is a risk time for developing vitamin deficiencies. So I think it's more than just the anatomy, and we need to think about all these aspects of care when talking with our patients and caring for our patients who are at risk for vitamin deficiencies.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.